Welcome to Health Stealth Radio, where we move away from the mundane to gather insights from the shadows of enterprise and patient cybersecurity. Yes, we surely believe that traditional themes like endpoint software and zero trust are critical, but given massive advances in AI, remote and wearable device hacking, and data hostage negotiators, there's a much darker side to cybersecurity, and not everyone is quite willing to talk about it in public. Health Stealth Radio will thrive on these topics and encourage fireside spats to debate them. Here's your host, Frank Cutitta.
I'd like to welcome you to Health Stealth Radio today. It's great to be back with you. I hope you all had a great summer. I have the thrill of being with Josh Reischer today, who is the founder of Help Now. It's an interesting story. He's got an interesting personal story that brought him into this business as a physician. So I'd like him to tell that story. But first, Josh, what was your I'm sorry, it's Health Note. Josh, what was one of the things that was the most fun that you did this summer?
Spent some time in California and New York. I was just in Vermont for a week. And Vermont was beautiful. It was nice and green and by some rivers and by the forest. And it was relaxing and very fun.
Could you just give our audience a little background of how you got into this, your academic background, and then what brought you to the company like this that you're launching?
Sure. My background was not medical at first. I had studied political science and business. I went back to school to do all the pre-medical sciences before med school. I ended up going to medical school, doing residency in internal medicines, so mostly focused on adult primary care. And while I loved seeing patients, I just saw all of the operational and administrative burdens that physicians are and were facing, and really just became passionate about that. And I recognized that it was more challenging for people to try to solve those problems if they didn't really understand those problems. And that's really where we started. The idea was, how do I have all the information I need about a patient so I can best take care of the person who's sitting in front of me, so I can focus my time on them while they're there. They spent half their day coming there, waiting, being there. And if you only have 30 minutes or sometimes less with a person, it's helpful to know as much about them as you possibly can before they get there, to make sure that their time is valuable as well. So that's really the premise of Health Note, is how do we gather, prepare patients for a visit, and then for providers, optimize the time that they have with their patients to really make sure that they can make the right decisions for the people who are sitting there with them.
Tell me a little bit about the technical details of what your product does that might be different than the competition.
Yeah, so we have a few product lines, but the first product line that we came out with was essentially an intake product. And while most intake products focus on gathering the basic information handed at the front desk, which is very helpful, right? Essentially digitizing the paperwork that's handed to you when you show up at an office, or potentially improving what the EHR has sent you before a visit. We tried to go several steps further. First of all, we understood the patient population. When we first started testing the product, we wanted to make sure this is easy for patients in their 60s, 70s, 80s, and above. Something that was like, if they have a smartphone or if they have a computer, that they could use this. But also complex enough that we can ask the questions a provider would ask. So if you're going to an orthopedic visit, you may know that it's not really just an orthopedic visit. It could be a hip specialist, a spine specialist, a sports medicine specialist, a pediatric orthopedic specialist.
Right.
They all have different needs. And so we really focus on gathering the right information at the right time. So we'll look into the EHR, we'll understand who you're going to see, why you're going to see them, and then ask relevant questions. So we're reading data from the medical record, we're asking you relevant questions, and then we're sending that information right back where it belongs in the EHR. So not just into a PDF, copy and paste, but actually in the workflow that the physicians, nurse practitioners, PAs, and others might actually use. So for them, there's really there's no change in their workflow other than information now flows into where it belongs. So it's as if a medical student went in to see a patient before they show up, and all that information flows in. Now, on the AI side of things, we recently launched an AI scribe. And the idea is that this is going to connect with the pre-visit intake. And so with the AI scribe, essentially, we're listening to a conversation, transcribing it, using AI to take the transcript and summarize it in a way that's actually useful for the physician. But now we have access to not only the information that's in the chart, but also information that was recently just given from the patient, and can combine all of that information together to really just have a more comprehensive documentation that, again, just goes directly into the chart.
Interesting. I know one of the things you've talked about is how many areas of duplication there are, especially on intake. Could you tell our audience where you're seeing some of those more duplicated tasks that kind of product would eliminate?
Yeah, very often, I think we've all experienced it, myself included. You fill out something online. Then you get to an office and they ask you to do it on a piece of paper. Then someone goes there and starts typing it in. And you wonder, you're like, is there any communication between any of these systems, right? Why is someone going through this and asking me again if I already filled out something online and I already did something on a piece of paper? And then what does the doctor say as soon as they walk in? They say, what brings you in today? Right. And so there's just this line of miscommunication. And what we've seen is there's a variety of reasons, right? It's not one simple reason, but very often irrelevant data is being collected. The information is often not going where it needs to go, or not in an easily readable format. So it might go somewhere in the chart, but not where the provider would actually expect it to be. So then you end up getting a frustrated patient who says, well, why did I do all this? If nobody looked at it. And then for the provider, they're not really being helped at all, right? So if you give a provider very basic information, it's better than nothing, but it's just not enough to really save them that much time. And very often, especially people who have a lot of complex issues, they might be coming in for 4 or 5 different things or more. And going through that long list of items that a patient wants to review can often be very time consuming. So the more information you have up front, the more you can actually take care of those things and have a discussion, as opposed to just data gathering.
So since you started this, where has AI moved to that makes it more advantageous and does things that you never thought it would do? Where is this going that you're going to be able to use it as it gets closer to clinical decision support?
I think it's really along the lines of synthesizing large sets of data and actually being usable for a variety of different physicians, specialties, and preferences. What we've seen is every doctor wants something slightly different for a variety of different reasons. Writing their notes or documentation is a very personal thing. It's how they synthesize what's going on, how they report out. It also affects billing and coding and other things, right? So there's a lot of reasons for documentation. And what we've seen is AI really enables us to manipulate a transcript in a way that's synthesizable for a physician, but also customizable in a way that before was just not readily feasible at a reasonable price. Now, for a fraction of the cost, we can really give doctors what they want. We can prompt what they need. And that's a big part of what we see is, how do you make a user interface that's easy enough for every physician to actually get what they want? And that is actually now one of the problems to be solved. It's that the technology enables it, but then how do you enable the end user to use that product, right? Someone who's not a prompt engineer, right? And maybe you can have a system administrator help physicians, but they're not going to do it for 500 people, right?
Exactly.
How do you enable a physician to really just get what they want in as few steps as possible?
So I'm interested in the collaborative group and the buying process for a product like this. So when you go into a provider or a healthcare enterprise. I mean, who's part of the dream team that you're talking with when you get there? Who's the collaborative team that buys this? And then I'm curious about the onboarding aspects of getting people to use it well. I mean, I was in for a long time during COVID myself. I had a personal COVID experience, and I watched how poorly telemedicine was rolled out. It was great. It happened very quickly, but the problem was it happened very quickly. And I ended up seeing a lot of male pattern baldness where people just were, I saw the top of their head and clicking on the keyboard, nothing else for a 30-minute call. Tell me about how you put together a team within the organization that can deploy this and can train people to do it.
Yeah. So to answer your first question, like who's part of the buying process, of course, it depends on the organization, but typically there's someone operational, someone medical, and someone technical. Mm-hmm. At a large organization, it might be a chief medical information officer, a chief medical officer. There might be a VP of operations, some either clinic manager or someone above that person, depending on the organization, who really understands like what are the workflows in the clinic themselves. At some health systems, they have, let's just call them like innovation arms. And sometimes those innovation arms are the ones that evaluate, review, look at new technologies and help implement on a small scale. So that's often where it starts. In terms of implementing the technology itself, I think you hit the nail on the head on the question of how do you implement? How do you train people? We tried to design the software in a way that needs minimal, if no training at all. So we have multiple users, which is kind of interesting. So on our intake product, the patient is the first end user, actually. So we're reading from the system. We would see, Frank, you have you have a meeting with a physician, or it could be a call, next Tuesday at 2 p.m. We're going to send you a text message. So the first problem to solve was, if we can't make it so simple that you can use it, everything dies there. Mm-hmm. So we have on average about an 80% completion rate, which is really high for getting patients to fill out information before a visit. Now, that number varies, right? For pediatric groups, it might be in the high 90s, and urology groups, it might be in the 60s, depending on the patient populations, et cetera. It varies, of course. But that's the first end user. The next end users are really who's consuming that data. So if we're collecting things like demographics, insurance information, and whatnot, that's the front desk. So we tried to make it so simple that they don't need to do anything. It's just the information shows up where it belongs. They don't need to press any buttons or anything like that. And the same thing for the physician. So the training for that product is really awareness, not much training itself. Sometimes the awareness is critical for a number of different reasons, but there's not training in like they need to take an action, because we realized very quickly, if you're not integrated very well into the workflow, not going to work. On the scribing product, I'd say that there's, for some people, there's zero training needed. And for others, there's a little bit of understanding what needs to happen to manipulate their note a little bit, to create templates and whatnot. So some people pick it up and figure it out on their first try, and some people need a little bit more help. And what we are actively trying to do is make that as, we'll call it self-serviceable as possible, so anyone can use it. But we know there's always going to be some folks who need a little bit of help.
How would you characterize the skepticism, maybe generational skepticism, about deploying these kinds of products? Is it, the Marcus Welbys versus the Young Turks? I mean, is it, are you finding those barriers are no longer there?
It's interesting. I wouldn't say it's not really like generational divide. It's sometimes just preference divide. I'll give you an example. I was talking to 80-ish-year-old physician. We showed it to him and he's like, this is great. And he started using it right away. He had some technical trouble. We got on a call with him. He had some microphone issues, basically like technical on his side issues, but he was so excited to use it. He, called up our team. Our team spent 20 minutes with him, basically helping with his computer. It wasn't necessarily our software, but it becomes our, problem to solve if it's not working well together. And then we have younger people who say, well, I like typing my notes because that's how I synthesize information, right? And so some people, it's not part of their workflow. My guess is that all new providers coming out of residency in 5 years from now, it's so part of their workflow, they don't know how to write a note in the same way that people are doing it now. They know how to review something quickly. They know how to spend their time in a totally different manner than is being spent today.
Really interesting. You mentioned the electronic medical records, EHRs, whatever the acronym. I'm wondering, everything comes down to a couple of things these days. I mean, obviously, interoperability is key, and there's security. So, tell me a little bit about the interoperability aspects of the product and what the challenges that you might have had to overcome to get this to work across platforms.
Yeah, there are many different EHRs. There are many different ways of integrating into the EHRs. Some are using general standards like HL7 or FHIR. These are more general standards that EHRs can comply with or are required to comply with. Sometimes the integratability there, depending on what you're trying to do, whether it's take information out or put information in, may not be exactly what everyone's expecting. So some EHRs have what's known as private APIs. So basically, they have their own proprietary way of putting certain pieces of information in certain places. And because a lot of what we do is put information where it actually belongs, we're typically working with medical record systems that have that capability. Not all of them do. I'd say more and more are opening up those doorways and channels. So if we started our company about 6 years ago at this point, it's gotten a lot easier than it was. Some medical record systems are more open than others. Some of them give you what's called a sandbox, right? A way to sort of play with the system and see how it interacts, and some do not. And if you can imagine, if you're building something and you've got your eyes covered, it's a little bit more difficult to build and to test, right? And so some of them require that you have a health system to work with you to do that. And as you probably know, health systems are very busy and they don't necessarily have the time to do that, right?
So I hear, yep.
So, mileage varies depending on what you're driving there.
And things in rearview mirror are closer than they seem.
Exactly.
So, you used the word sandbox, and I could show you. I had it as one of the questions that I had here. Are there certain departments which are great launching off points where you can develop a more rapid sense of adoption and security and buy-in, I guess is the word that I'm looking for, versus others? Are you see traditional? I might be grossly generalizing, but I'm a student of corporate culture and healthcare culture. Are there some departments that just are more resistant to this stuff than others?
I'd say that most specialties are actually interested in optimizing what they're doing. It comes down to individuals, and then it often is dictated by the organization itself. They may see sometimes there's just relationships and they say, hey, this office or this clinic loves trying out new things and is great at giving feedback. Right? Okay. Because some groups want to try things, but don't necessarily have the time or capability to give feedback to improve something. So if it doesn't work on day one, they're not the earliest adopters. In terms of specific specialties, sometimes the hospitals are looking at who are the largest revenue drivers. And so they're thinking about if this specialty adopts and there's value there, it's their quickest way of saying, okay, this makes financial sense. And so some of the surgical subspecialties come to mind. But then there's also the, let's say, internal medicine or primary care groups, which maybe are not as high revenue opportunities for the health system, but there's many more of those folks.
Right.
right? So,
Right.
it really depends on the organization is generally what we've seen.
You sort of led to the next question. What are some of the metrics that they're using to justify the investment? And I mean, this is not we're not talking about billions of dollars of investment, but even at the levels that you're talking about, reasonable investment. What are some of the KPIs that they're looking to get back?
Yeah, when they're looking at hours, very often completion rate. Completion rate can be seen as a proxy for how many patients are filling out how much information that's then going and then being used by the providers,
Right.
as a proxy for how much time, availability, et cetera, there is. It's a little bit more difficult to actually measure what are the financial outcomes. So, for example, some organizations may be driven by, hey, there's this specific questionnaire or this specific screening that we get reimbursed for. So there's many, many of those. But when you're talking about a whole organization and multiple different specialties, some are driven by that, some are not.
Right.
So that's a big piece of it. And then, of course, just user satisfaction, right? Like, is it actually saving time? Is it enabling them to provide better care?
I teach an informatics course, and we're always looking for what kind of data exhaust comes off of products like this and in healthcare in general. So, what is some of the data grabs that you're getting? Obviously, completion rate is that's the basis for one of the KPIs that your product is based on. What's some of the other data exhausts that's coming off of this that you might not have expected when you first launched the company, that we're starting to find out new stuff? AI is helping us to find that kind of new stuff, or maybe not. So how about some of the data plays on this?
Yeah, I mean, right now we essentially use the data to improve the product itself. We're not selling the data or anything like that. That being said, we're gathering a huge amount of data from patients, some of which would probably have been said anyway in the clinic, and some may not have been because maybe they didn't have the time to say it. So I think the opportunity to get 15 minutes sometimes, or sometimes more, worth of information from a patient before they even show up can be huge, right? So when we compare what we do to what typically the medical record system would do, just as an example, an average might be like, oh, you gathered, if they can gather, let's say 10 or 12 questions, we might gather like 90 questions, which could be literally hundreds of data points of questions, because it's both this happened or this didn't happen. You chose this or you didn't choose this. There's a lot of data there.
Interesting. So we talked in another conversation, we talked a little bit about cross-cultural aspects of products like this. I'm wondering where you see that going, considering the ethnicity and incredible diversity. We're not even talking about leaving the country. We're talking about leaving the block in some areas. How do you accommodate that in terms of building an intelligent product based on accents and terminology, levels of pain, things like that?
That's a great. I just had 3 conversations about this yesterday with clients.
Cool.
Exactly this. One was a federally qualified health center, and they were talking specifically about language adoption, et cetera. And so what's really cool with AI is, like, with our ambient product, they had 2 other products that they were testing out, and they both had Spanish and English, and they said those are helpful, but actually we have a fairly large Russian and Farsi speaking population. Can you do that? Open up the product. I show them the dropdown, and one of the products that they were using has been in the market for 10 plus years. And so it's really interesting to see that this is a new product that we're launching, and right out the gate, we have about 40 languages available.
Wow. That's
from
cool.
the get-go. And then we start testing it on the call so they can see how it works. That was not possible before. So it's really, really cool. The other group was a primary care clinic that basically has about 95% of their patient population is Spanish speaking. So that was really, really important. What was also important to them is not that it could just do Spanish translation, but could it pick up a conversation where both Spanish and English are being spoken?
Wow,
because while it sounds similar, it's not actually the same. And then we showed them how that works as well. So it's actually extremely important.
Where do you see this advancing that's going to add a completely different complexion to what the product does today?
Yeah, from my perspective, there can and should be more ability to use this data to, one, help inform and better communicate with patients, because I think that's still a huge problem. Patients often don't understand or know about their plan before they're coming in or after they leave. And the same thing for physicians. As the amount of data grows, it's becoming increasingly obvious how, memorizing things in med school and residency is going completely irrelevant. Yes, it's good to memorize things and to understand things, but the amount of data is becoming gigantic. And now the searchability of it with things like ChatGPT, whole nother level of being able to find what you actually need. And now these insights can be surfaced immediately based on data-driven approaches, right? Like, here are the labs, here's the radiology imaging, here's what the cardiology specialist said, and now I'm seeing the patient. What should I do? Right. And so I think it'll bring more standardization over time, because, you go to one hospital and they have this level or standard of care. You go to another hospital and it's different. With technology, there's really no reason that you couldn't get the same level of care and understanding anywhere in the country, right? Like, you shouldn't have to only go to a, name the really large system in the state or part of the country that everyone flies to because they have the best coordinated care. That should be accessible anywhere.
Is there anything that you're seeing in terms of the world of prompt engineering that's applied to the work you're doing?
Is making a product that's easy enough for literally anyone to use. And I'd say, you might say, oh, something that's easy enough a kid can use. I would honestly say easy enough a physician could use. and the reason I think that's okay to say is because they are so busy and distracted by so many things. They don't have the time. It's not that they don't have the ability or capability. Of course they do, but they don't have the time to learn these kind of things. So it needs to be easy enough that a physician can use. And I don't mean that facetiously. That's what we are learning in this process. They spend many, many years focused on one thing, on medicine, right? They didn't go to school to be computer experts. Yes, you need to be somewhat savvy to a degree, but they're definitely not going to become prompt engineers. Not yet, right? At some point, they might be.
This was a great interview, Josh. I'm really glad we had a chance to get together. I'd like to thank our audience on Health Stealth Radio for joining us today, and then please tune in again for our next episode, which will be coming up next week. So thank you.
Thanks so much, Frank.
Thank you for joining us today in the shadows for this episode of Health Stealth Radio with Frank Cutitta. If you like the program, please be sure to share your comments on our social media sites, or feel free to contact us with suggestions for new and stealthy show themes. We look forward to welcoming you again for our next broadcast. In the meantime, stay safe out there.